Our body produces many different hormones. We've talked about testosterone, there's estradiol, there's growth hormone, there's, melatonin, but how about thyroid? Thyroid's a hormone that has many different symptoms that might be related to testosterone and maybe not. We're going to discuss a little bit about thyroid hormone, thyroid disease. In particular, when we talk about thyroid hormone, we're normally talking about low thyroid, though high thyroid or hypothyroid could be just as problematic, and just kind of unpick a little bit about what thyroid is. Do you need it? We're here with Dave Lee again in London with us, talking about this new topic, thyroid hormone. Do you need it? Should you worry about it? Is this the hormone that kind of goes wrong when nothing else seems to be working on your normal TRT? Are you just coming through because you're just curious about thyroid hormones? Or you think you have a low thyroid? I'm going to let Dave lead off and tell us a little bit what his thoughts are when he sees these guys coming through aren't quite right, I imagine, and now we can look at their thyroid hormones.
Yeah, absolutely. So a couple of things to preface the conversation. Hyper and hypothyroid sound like the same word when you say it quickly. So hypo meaning low, hyper meaning high. If we're saying something quickly, we're probably saying hypothyroid, meaning low. So the majority of the time that we're looking at thyroid dysfunction, it's low thyroid. You have something called Graves' disease, which is hyper overactive, rare, much rarer, much. So the second thing is that because we spoke about testosterone before, I've kind of stuffed up my thyroid analogy. So thyroid should really be looked at like the engine of the body, but I talked about testosterone being the engine. So I'm going to talk about thyroid being the furnace. So you can think of thyroid like your metabolic furnace. It's what is going to govern what's called your basal metabolic rate, which is how much energy you burn doing anything or sitting around doing nothing. And this is a major factor in, when people look at health and fitness, like calories in, calories out. Thyroid's a big factor there. So when we're looking at thyroid dysfunction, we're looking at metabolic sluggishness. We're looking at kind of like having a furnace that's too small to heat the body. And this kind of leads me on a bit of a tangent here, is that when we typically think about hypothyroid symptoms in a medical context, we think about cold hands and feet. This is more common in women who are more commonly diagnosed with hypothyroidism because women run a little bit lower than men in terms of heat. So while you can have cold extremities as a man with hypothyroidism, a lot of the time that's not going to be your primary symptom unless it's quite severe. Typically, your primary symptoms are anxiety, depression, low energy, low libido, poor sexual function, mood disturbances, issues gaining weight, issues exercising. Sounds like low testosterone as well. So if we have a Venn diagram and if one is low testosterone symptoms and one is low thyroid symptoms, they are going to be completely converged as one circle because they are the same thing. Because testosterone impacts metabolism. Testosterone also impacts neurotransmitter function like dopamine, immune function, all these different things. Thyroid does that too. So that there is a interconnected relationship between thyroid and testosterone, but there's also an interconnected relationship with all the hormones in the body, because the body is not just a testosterone producing machine where testosterone is the panacea for all your problems. And the reason why I like looking at thyroid is that thyroid is a less invasive treatment than testosterone. It's oral, doesn't involve shutting down your natural production. So I think that it's extremely important for the patient to have their thyroid levels run before they go on TRT, because if they have Hashimoto's thyroid or if they just have subclinical hypothyroid from other issues, that might actually be the lower hanging fruit that could prevent them from actually needing to go on TRT. And then they could pull the trigger on TRT, they're not going to get better, and then they're going to need thyroid all along.
So for everyone watching, Hashimoto's or thyroiditis is an autoimmune disorder where your body attacks the thyroid gland, and which can cause symptoms of both hyper elevated thyroid because of the destruction of the gland causes a massive release in thyroid hormone, followed by times of very low mood and low thyroid production because of the damage done. And it's always kind of changing over time for that. And you can measure this by antibodies that are released as a result of the body attacking itself. But yeah, it's quite a complex disease, the Hashimoto's bit, versus traditional, I think, classical hypothyroid, the low thyroid, which usually, and again, they also have the ranges, and there's their own set of politics involved with what constitutes hypothyroidism.
Yeah.
What level do you treat at? Which level do you try to force a TSH? Because interestingly, what we found in the more traditional, again, endocrinology setting is many of the tests that they run are simply TSH and, if you're lucky, free T4.
Yeah, if you're lucky. Yeah.
And, on all our panels, and then we've seen some competitor clinics, all they do is TSH and they'll do free T4, but we always do TSH, free T4, free T3, and the antibodies.
Yep.
Because I think we've noticed that if you've got these antibodies in your brain, you get this brain fog, you get this feeling you're just not feeling right despite being on testosterone. So we've always thought it was important to have that data from the beginning.
Yep.
And kind of watch the patient through. If they had this this was a red flag, and maybe we can stop some of the problems and preventing any of the delay of them feeling better by addressing it sooner rather than later.
Yeah, and there's a couple of things here which get confusing. I've done a whole lecture on this and written a book on this, so we might put the links for that in the bio if people want to go a bit further into it, because I have slides and I can explain it a bit better. But there's this situation of being like, which is a classic example, is that a guy will come in, he's got suboptimal testosterone, suboptimal thyroid, and it's going, well, what do I do? And this is why it's so great and important that you run the antibodies, because that, to me, and this is just how I do it, I'm sure there's other ways you can do this, but that's the determining factor, because there is research that shows that if you treat Hashimoto's, this will increase testosterone, because that makes sense, right? Your body's attacking its own furnace, the thermostat's broken, it makes sense that androgen production is reduced. So if someone's got low testosterone and low thyroid, we can go, well, if Hashimoto's is involved, which is autoimmune, genetic component to it, it means that this isn't going away. You can pump the testosterone up all you like, you're still thyroid got an issue. But if you fix the thyroid, we now have a chance that testosterone is going to come up. It might not, and you do that first, and then you might still need the TRT, but at least you exhausted that option and you potentially prevented a unnecessary, quite invasive health intervention. But if there's no antibodies present and the thyroid is subclinical, then what we also find is that if you increase the testosterone, that subclinical hypothyroidism can actually resolve. So if you're in a situation now where it's not autoimmune and testosterone and thyroid is low, you're going, well, this one's actually now going to be more likely causing this. And one of the big mistakes that I see other clinics make, and I'm not going to name names because everyone might still be learning, that's okay, but that's why you need to go to an expert, is that if someone's got subclinical non-autoimmune thyroid, and I'm aware this is getting confusing, so watch the lecture if you need to, it's all for free on YouTube, is if you increase the testosterone and the thyroid together, if going on TRT resolve the hypothyroidism, now that extra thyroid hormone could put you over into hyper category. So you could be netting too much thyroid. So the way that I like to do it is always check everything, always check autoimmune, because sometimes the thyroid panel might look okay on that day if you've got Hashimoto's because you had a decent day. But if you've got antibodies there and you've got symptoms going, okay, well, let's start by treating this. But if those antibodies come back negative, I think that people should get the testosterone up first before assessing the thyroid, because sometimes that can bring the TSH down and bring the T3 up because you're removing the stress in the organs.
But also with Hashimoto's, you might not have antibodies left because you had antibodies in the past, and your thyroid has been so damaged that you don't show them anymore.
That's when the TSH would be quite a bit higher, and that's when we'd be looking at something that would be a bit more severe, I would think. But absolutely, and Hashimoto's is tricky. And the other thing that I think, and maybe you can comment on this as well, because you've also got experience in this field, is that I don't know if this is a term, so maybe I've come up with this term. If it is, it's mine. Subclinical Hashimoto's, where you've got symptoms and you've got antibodies, but they're not above whatever the cutoff is on your lab. You might be, let's say the cutoff for one of them is, and we all use different units. Let's say the cutoff's 115 and your antibodies are at 90. They're not at 0, they're present. And if you've got an elevated TSH, low T3 and symptoms, and you've got some antibodies but not none, is that Hashimoto's or not? Well, they would basically say, you're healthy, you're sick. Whereas we know in reality there's a spectrum.
Well, what about the symptoms? And that's what's so hard about the thyroid, is so many of the symptoms of the thyroid match up with others. So let's say you're on TRT.
Yep.
And then you add in but you have still have the symptoms that might be related to thyroid dysfunction or hypothyroidism.
Yeah.
Is it because the TRT is not working, or is it because you have hypothyroid, some form of hypothyroidism? And it's it's a tough. I know the endocrinology society is the ones who love to beat up on, but they're very. There's like you either have it or you don't, and you either go above this TSH or you don't have it, or you don't treat it, and I can somewhat see why, because it's very complicated to get it right, and there's so many more blood tests that you require, and there's so much more messing with it. But then if you can get it right or get some thyroid in, you can feel a lot better.
Yep.
But too much isn't good either.
And I have found, and we spoke about this before, is that thyroid symptoms and thyroid issues are rampant here in the UK. And that was something that I found very interesting, because I work with guys all over the world, but predominantly Australia. But I found that thyroid problems are very concentrated here in the UK. So I always check antibodies with my guys in the UK. And I don't know if that's to do with, the lack of vitamin D, there could be so many other factors I'm not aware of, but it's so important that we fix the thyroid, because going back to that analogy of if you have a hammer and everything looks like a nail, this is one of my gripes with people taking things too far to an extreme, which is that blood work doesn't matter, it's all about symptoms. Going, okay, well, that means that if you feel like shit to any degree, you just need more testosterone. At what point do we draw the line? If your blood pressure hits 180, you're at a gram of testosterone a week, oh, I still feel crap, I need more. No, it's why it's so important that we look at the blood work and we look at things, pragmatically in terms of how the body actually works. But it's so important that we're assessing the thyroid function along with the testosterone, because the other thing to consider as well is that if someone has hormone decline, assuming it's not to do with a testicular injury, whether it's age-related, secondary due to stress, or to do with environmental factors, I think that it is ignorant and incorrect to assume that that individual is only going to have a testosterone issue. If you've got an issue with one hormone production, it doesn't mean that you have an issue with your thyroid and that you have an issue with your adrenals, but I think it means that there's a good chance that you might, and that needs to be investigated.
I mean, I know some people will use iodine who think they might be low on the threshold, but that could lead you, especially if you have Hashimoto's, to a whole other area that you don't want, because iodine can also frustrate or upset the conversion of T4 to T3. So I guess for people who are watching, with thyroid, your active hormone is the T3.
Yep.
That's the stuff that does all the good, and more of the storage hormone is the T4.
Yep.
So, and iodine plays into how I think it's converted over one to the other.
Yep.
And not to mention, you can have certain stress issues that lead, rather than T3, it converts to reverse T3. There are some practitioners say just ignore that, doesn't matter, it's not important. But in theory, the reverse T3 not only is made, which wastes the T4, it also can sit in the receptor for the T3 and not allow it to do what it needs to do. So it's so very complex, this area. And once you go down that rabbit hole or start doing it, you want to find a practitioner that can kind of help sort you. I find that sometimes the simplest approach is the best approach. And normally the starting point is for treatment is T4 treatment to begin with. Though there are others who will talk about a natural desiccated thyroid hormone, or even two synthetic T4 and T3 treatments. So what's your preference?
I personally have never seen iodine fix a thyroid problem, but I've also never seen an iodine deficiency in Western countries. I've run many iodine labs. I stopped running it now because they were just a waste of people's money. I have seen people megadose iodine, like Lugol's iodine, like I can't remember the name of the tablet, but the 12.5 milligram iodine tablet. People think they're getting detox reactions. No, you've got iodine poisoning. It's making you sick. I've never seen iodine and tyrosine, which are the two thyroid cofactors. I've never seen that resolve hypothyroidism. Could that boost your natural thyroid production from good to great? Maybe. Depends on your diet. But if we're talking about someone with actual either subclinical hypothyroidism with symptoms, no. Waste of time. So when it comes to the different treatments, I'm big on reverse T3. I think that some people don't need to check it because they can guess what the result's going to be based on other factors. But I like to try to prove myself wrong. So I'll usually test it. The problem with reverse T3 is it's expensive here to test. It takes a while to get back. So in Australia, you've got the cost of your comprehensive lab, and then you've got the cost of reverse T3, and they're the same. So I often don't run it at first, but I'll run it as a follow-up if I've got reason to suggest it might be high, because reverse T3, in my experience, if it's elevated, will show a high TSH and a high T3, or maybe mid T3. But generally, it shows moderate to high T3 and high TSH. And what this is suggesting is that, if I use my water glass analogy, is that the glass is actually full of water, but the body's saying, I want more water, I want more water. So if that TSH is elevated, even if your T3 is high, it's going, well, that T3 is not working at the receptor level. Why is that? Because reverse T3, literally opposite anti-T3, is taking up the receptor site and stopping it from working. I used to teach meditation, and one thing that we would talk about is that everyone knows that if you're chronically stressed, you gain weight, your metabolism goes down. This is how that works. This is the mechanism. It's reverse T3. So I like to call this secondary hypothyroidism, which is that you don't have an autoimmune problem, you've got a stress problem. And this is why I personally needed thyroid for a period, is that I've got two quite severe spinal issues which cause pain, which I've worked on now, which is why I no longer need thyroid. But I personally needed T3 monotherapy, because if I put any T4 into my body, it just jacked reverse T3. So this is why I tend to go for either T3, T4 in combination, or NDT, or sometimes T3 monotherapy, but not most of the time, because if someone's got a propensity to overproduce reverse T3, which sometimes you can use cortisol and prolactin as a proxy for overstress activity, is if you put any more than 50 micrograms of T4 into there, you're just going to create more of a problem than you're going to solve. And I think that's why T4 monotherapy has such a bad rap online. But I also think that, and I've seen it many times before, sometimes people can just get by with a little bump in T4. Massively long half-life, once a day dosing, smooth and consistent levels. But I find that if someone needs like a decent amount of a thyroid boost, they're probably going to have just as much of an issue making T3 from T4 as they are producing T4 itself.
Now, what about, and then with the endocrinologist, TSH is the holy grail. Everything is revolved around TSH,
Yeah.
and the TSH threshold is like over 4.2,
Yeah.
for you to be considered even,
We're 4.5 in Australia.
or so, yeah, or was it a preclinical hypothyroid, or
Yeah.
versus, but they don't consider true hypothyroidism until you're like 8 or 9, or
Really?
yeah, so it's quite high, especially in the UK. But then on the opposite, when you're on treatment, they'll only look at the TSH as the guide for, are you getting enough thyroid or not, which isn't ideal, because we talked about the benefit of the free T3. If your free T3 is too low,
Yep.
the endocrinologists are looking at just the TSH. And it's one of the more frustrating bits to follow, because unlike testosterone treatment, you put in exogenous testosterone treatment,
Yep.
and you end up suppressing your LH and FSH, usually at nearly any amount of testosterone. There are a few rare cases I've seen. I always joke, like Jurassic Park, life finds a way.
Yeah.
In some cases, the LH and it will stay at a lower number, but still be present, but it's very rare. But for TSH, it's still, it's almost an opposite, like it's a strong TSH. Try to bring that number down by using an exogenous thyroid, and then hopefully that converts into your free T3. And then if that TSH gets too low, now you're considered hyperthyroid. So you got too much thyroid. But they don't always look at the outcome measures of how high is the free T3, how high is the free T4. But then, and it's a strange one, because you would think, well, this test at trough. And I've seen in myself and in some patients, the trough doesn't always give you the highest TSH level either. I've also seen, after taking the medication in the morning, doing a test midday or at 3 p.m., I actually have a higher TSH than I did first thing in the morning after, not having anything since 24 hours earlier, or even my evening sip. So it's a really weird one. It's so frustrating for patients once you go down to try to nail it. So I think a good clinician will look at a bit of symptoms and a bit of the biomarkers. But I don't know if there's much more fine tuning you can do without driving yourself mad.
I think sometimes we try to oversimplify how the body works. And I think that this reductionist approach to biology kind of bastardizes the extremely complex, interconnected system that we are, that we don't really even properly understand yet. And TSH, T3, and T4, I mean, up until I'm not sure exactly when it was. The late Dr. Ray Peat spoke about this. Yeah, they only worked out how to test that, quite recently. But they were treating thyroid well before them. They were using waking temperature as a proxy for thyroid activity, which is not a perfect proxy because digestive issues will destroy your waking temperature as well. But it's showing how everything is feeding back and interconnected. And in Australia, I'm not trying to have a pissing contest with whose country is worse for thyroid, but this is my card to play. Is that if your doctor orders TSH, T3, T4, and the TSH comes back below 4.5, the lab won't even run the T3, T4 because they go, well, you're fine. Now, maybe I'm down the conspiracy rabbit hole of a whole bunch of people with hypothyroidism getting diagnosed with depression and anxiety, or one thing that's also very common is adult onset inattentive ADHD as well, because people go, I can't focus on anything, I have no energy, I can't concentrate. Could be hypothyroid, because T3 is very important for dopamine production, and T3 is also one of your body's primary aromatase inhibitors as well. So now we're going, okay, well, if someone's coming in with these side effects on TRT, more reasons why we need to be looking at the thyroid. So everything's very interconnected, and looking at one number and going, if this is above this, then it's not a problem, and if it's below this, it is. It's like saying, if you are morbidly obese, you've got a problem, but if you're less than morbidly obese, you're healthy. It's like, no, it's not really how it works. So there's everything's on this spectrum. And it can be difficult with thyroid because one of the advantages is, like what you mentioned, is that we're not wiping out the natural production and replacing it like we are with TRT. We're topping it up. I actually wish TRT worked like thyroid. We could just top it up. Yeah. But it's why thyroid dosing is so much more varied, because your natural production is still at play. And the thing that makes it more tricky is that your exogenous thyroid dose will remain constant, but your natural thyroid production is going to vary by all the things that impact natural hormone production. And if you've got Hashimoto's, it's going to vary even more than that. And that makes it really tricky. So looking at TSH as the marker to determine whether your thyroid is working properly, if it's elevated, I think that that's a good marker that you need more thyroid. But if it's suppressed, it doesn't mean that your body's satisfied, because part of the reason that your thyroid is not working may be that feedback mechanism isn't working. And this is something I see a lot in Hashimoto's, going back to the water glass analogy. If the water's T3 and TSH is the signal to the waiter to go, hey, I want some water, what usually happens is when there's enough water in the glass, you go, yeah, I'm good. And that means low TSH, high T3, everything's sweet. But what if T3 is low and that signal's low? Well, then your glass is empty, but your body's not saying, I want any more. It's not making any more. So then to go, okay, well, we're just going to stop giving you thyroid hormone once you reach a certain TSH level. I mean, that might mean that it's going to come up to here, but that signal's not working. So we can't rely on that signal to go, do you need more water? Because it's not working properly. And that's part of the damage caused by Hashimoto's. So it's tricky when it comes to thyroid because the dosing varies. There's more protocols that work differently, and there's nuance, because if you've got reverse T3 as an issue, this is the other one that I like to look at, again, going back to my car analogies, is if reverse T3 is high and you've got hypothyroid symptoms, your body is pumping the brakes on your metabolism, and it's doing it for a reason. It could be a psychological reason, but it's still a reason. So if you come in and your body's going, I'm pumping the brakes, if you come in and pump the accelerator with more T3, you're not going to have a smooth ride forward. You're going to stutter. And that's what happens. People solve one problem and create another one. I feel more energy, but now I'm sweating buckets and I can't sleep. So what we have to look at in that analogy, the logical thing is going, okay, well, let's work out why the body is pumping the brakes and how can we alleviate that? So, things like if you've got chronic pain issues, seeing like a rehabilitation specialist to be able to fix that. If you've got issues with psychological stress, getting to the bottom of what that is. There are so many factors that can cause high reverse T3 can also be caused by crash chronic dieting. It's why people look at reverse dieting to fix that down regulation of metabolism. So there can be a lot of lifestyle and underlying factors that we might need to look at and go, okay, maybe throwing more thyroid hormone at this isn't the solution, or maybe we need a little bit of that and we need to bring this down a little bit so we can work with it. So this is why you probably can't do it yourself. Like, you need someone who's like, hey, I've done this a bunch of times before. I've seen someone exactly like you before. This is how we're going to move ahead. We might not be able to hit the bullseye the first time we do it because everyone's biochemically unique. I'm borrowing that one from Russ Scala, who we talked about before. Biochemical individuality. But what we're trying to do is throw the dart and hit the dartboard in the ring around the bullseye. And then we run the blood test, and then we move that to the middle of the bullseye, because now we've got data to go, okay, if this amount of T3, T4 or whatever got us to here, now we either just need to put it up a bit, back it down a bit, and then we can fine tune.
Fine tuning that's involved. I mean, myself personally, since I started thyroid, it's the fine tuning, getting it right, and keeping it in a safe range is important too.
And it's going to require more monitoring, because your natural production is going to change as you get older, as your health changes. You might lose a bunch of weight, and now you might not need a bunch more extra T3, or you might have your lifestyle habits go to disarray, and then that makes your Hashimoto's antibodies worse. Like, there can be so many different things that cause that, and that's why thyroid's a bit trickier to work with, is because your underlying production is going to be a factor, and that needs to be monitored, and then your exogenous dosing might need to be tweaked.
Yeah, we've pretty much covered this topic, I think. That's good. So if anyone has questions, if you've suffered from low thyroid, let us know. Or in combination with testosterone treatment, we'll try to answer the comments below. This is just really a starter course. We don't normally talk about thyroid in any great detail on the channel. I think it's been heavily testosterone related, but it's all interconnected. It's all very important, and it's something that when it's needed, at balance our hormones we can, and do help patients who need to have a little bit of thyroid involved. So yeah, thanks Dave for coming. It's been a really good day filming.
Thank you for having me.